So here I have already performed tonsillectomy on the left side. Now see, this is the posterior tonsillar pillar which is forming the anterior wall of the pharynx. I am going to make it the lateral wall of the pharynx. So I'll transpose it laterally. So before doing that, I have to cut the oblique fibers of the palatopharyngeus, and therefore I'm coagulating them before cutting so that there's no bleeding. And I'm also coagulating all the vertical fibers of the palatopharyngeus so that the lateral wall of the pharynx can become as stiff as possible. Now after doing so, let me divide all the oblique fibers of the palatopharyngeus along with the mucosa. So there's a small vessel along with the mucosa. I'm dividing all the oblique fibers of the palatopharyngeus so that this flap can go as lateral as possible. You can see that. And coagulating all the vertical fibers of the palatopharyngeus. And you can see this flap will go, leave it, release, all right. Now this flap will cover the tonsillar fossa and there will be no raw area in the bottleneck area. Now I'll take the vicryl suture and 2-0 vicryl round body starting from lateral to the pterygomandibular raphe, going along the anterior pillar of the tonsil. Then I'll take a full thickness bite into the posterior pillar from above downwards, coming out in the mucosa. And then again a full thickness bite from below upwards. The idea is to pull this flap laterally very gently. All right, you can see this very gently without any stress. And then along the anterior pillar of the tonsil, remaining medial to the pterygomandibular raphe, I've come out very gently. because our aim is to only take care of this bottleneck area. Then I'll take the first knot. Can you step it? Yes. All right. The second knot will be made little tight. So can you give me a scissor? Scissor, please. And the third one, I'll make extremely tight so that it does not open. No, no. Can you come to the right place? Don't. All right. So this one is very tight. Scissor. Okay, you can come out. And you can see the first one is loose. There is no strangulation. And as I said, there's a possibility that if you want to take one more suture over this, you can. And rather take one more. The flap is looking pulled because the tube, because of this mouth gag. The moment I release everything, this mucosa, which is seemingly tight, will not remain tight. It's only because this part is getting pulled, so it's tight. There's no actual stress on the part which is coming close nearby. I'm just taking one more for additional reinforcement. Very, very gentle. No stress. Just keeping it close. For sutures, it is said that you should put them like relations. They should be close enough, but do not strangulate. Don't put so much of pressure that they strangulate. If that happens, then they'll cut through. A philosophical thing, but very, very useful everywhere in life. Give me the scissor, please. All right. Now, what we'll do is we will come back to our barbed suture. We will. We had started from the right pterygomandibular raphe. Yeah. Thank you. Can you, little more? Little more. Again, starting from the exit point, remaining proximal to the exit, not distal. Going very, very deep. Why deep? So that it can lift up the whole soft palate. Will come towards the left pterygomandibular raphe and then go back from left to right. Again, very deep. You can see I am lateral to the raphe. To me, just waiting for the right instrument in my hand. All right. So we are lateral to the raphe, and you can see that this suture is actually pulling the soft palate anteriorly. It will not let it collapse posteriorly. But it's a 3-O. So I'll make a second round entering from the same place, going towards the left supratonsillar area. Can you give me the artery? Okay, I'm done. Then we'll come back towards the right side. Let me see if I'll get space without moving the tube, which is unlikely. So let me first take one bite, come to the right side of the midline, again a millimeter of two proximal, very deep bite, been able to come till the midline. Let me see if, yes, possible. Looks like. Hold on. So we need to go till the right pterygomandibular raphe. It's fine, fine. Just hold it. Sister. I'm still not happy. The direction of the needle has to be correct. If it is not, as I said, this space is a little cramped. All right. Now, from there, I need to go towards the pterygomandibular raphe. Lateral to the raphe. All right. And before cutting it, I'll just take a U-turn to lock it one more time. As you can see, I have no space. Can you push it a little more? Thank you. Yeah. You're fine. You're doing good. You're doing good. All right. Just one more U-turn before I cut it off. Scissor. Idea is no part of the suture should be ever seen outside because it's a non-absorbable suture. So what is the net effect of the surgery? Coblation, please. The net effect of the surgery is that I have reduced the AP length. Can you see the AP collapse is gone? Lateral collapse is taken care of by the tonsil, by the lateral wall being reinforced by this posterior pillar. And this suspension bridge will support the tongue. Not only the soft palate, it will also support the tongue which sits on the soft palate. So this patient, in spite of his BMI of 36 and AHI of 102, will do extremely well in terms of his choking and snoring. Thank you for watching suspension bridge pharyngoplasty.